All right, first we're going to look at upper respiratory medications in this lecture. Upper respiratory diseases and infections can involve colds, rhinitis, sinusitis, and pharyngitis. Antihistamines like Benadryl can be used. Most people cause quite a bit of side effects like sleepiness. So second generation antihistamines offer a little bit less sleepiness, and some of them are longer acting. Whereas Benadryl, a first generation antihistamine, works for about 4 to 6 hours. A second generation antihistamine like Allegra will make you not quite as sleepy, but also can work for up to 24 hours. Zyrtec also fits into this category. Nasal congestion can be combated with decongestants. Some decongestants are pseudoephedrine and phenylephrine. These often can cause high blood pressure. They can cause a higher heart rate and can lead to a higher risk of MI, actually. So they're to be used with caution. Expectorants. That's Mr. Mucus to you. It helps to loosen congestion. So if someone is on Mucinex, that's guaifenesin, it's not always mixed with a cough suppressant, and we tend to want people to not use cough suppressants unless absolutely necessary. If it's a real productive cough, we really don't want them to use a cough suppressant. They can certainly use an expectorant, get all of that stuff loose and cough it up. But we want them to cough it up. Coughing is a normal defense mechanism your body has to get some of that crud out and to get that infection out. So very often we don't want to suppress a cough with cough suppressant like dextromethorphan or codeine or some of the other opioids. This suppresses the body's ability to cough things out. Please remember that expectorants and cough suppressants are not the same thing. Expectorants, like guaifenesin, will help to loosen the congestion, while cough suppressants will help to suppress that cough. A good one to use it with might be a dry cough. And you're also using an expectorant. So a dry cough might be okay because there may really actually be nothing to really cough up. And in children, people shouldn't use them unless advised by their doctor, and only with severe coughing. Antitussives. Antitussive is the fancy word for cough suppressant, and we just talked about that. Pharyngitis is sometimes viral, sometimes bacterial. They are treated differently. Gargle salt water and take NSAIDs to reduce inflammation if viral, and let the virus work itself through. And they can go to the doctor and have an antibiotic if indeed it is strep. Strep would be the bacterial infection. We move on to lower respiratory medications. Please listen carefully and please take notes. Diseases and conditions of the lower respiratory tract are things like COPD, or chronic obstructive pulmonary disease, restrictive lung disease, asthma, chronic bronchitis, bronchiectasis, and emphysema. The first types of things that we give are bronchodilators. Definitely use these bronchodilators with wheezes and or reduced lung sounds. Sometimes reduced lung sounds are a sign that things are completely closing off. So bronchodilators will help to open up those airways. A bronchodilator is a short-acting rescue inhaler. Things like albuterol, which can go by the name of Ventolin, and ipratropium, which also goes by the name of Atrovent, work as bronchodilators. They work a little bit differently. Atrovent is an anticholinergic. It does have a bitter taste. It opens medium and large airways of the lungs. So, for the bitter taste, they can chew gum afterwards. And then, remember, it is a fast-acting anticholinergic, so it is able to open up those airways. Much more widely used, and certainly very effective, is albuterol, which is an adrenergic, so it directly opens the airways. It's very fast-acting. You do end up with much more of a increased heart rate, jitteriness. It's very difficult to sleep after getting it. This is the go-to rescue inhaler, but certainly Atrovent can be also a rescue. Now, the two of them together, albuterol, Atrovent, are called a duo neb. So we like to give this pretty often when we get these patients in that really need that. The duo neb, then we're using both the albuterol and the Atrovent at the same time. An old bronchodilator was theophylline. It's similar to the adrenergics. It also stimulates a high heart rate and tachycardia. Very chemically related to caffeine. So that is something to know. Write this down. Give short-acting inhalers prior to long-acting ones. This will open up the airways and then ensure that those longer-acting ones get down into the lower parts of the airway. Otherwise, you're just putting the long-acting ones in to places that haven't been opened up yet. So give the short-acting ones first. They are the rescues, they're the openers, and then the long-acting ones prevent closure. So speaking of long-acting ones, we're going to move on to the leukotriene receptor agonists and leukotriene blockers. They are not rescues. They do not cause thrush, and giving them at night can prevent attacks. Every once in a while you'll have someone who takes them in the day, but usually they're taken at night. So besides the leukotriene blockers, we also have something called salmeterol or Ceravent. That's a long-acting beta-2 agonist, and that too is a maintenance, not a rescue. Write that one down. Write all these down. Another long-acting type of a thing is a glucocorticoid. These are inhaled corticosteroids. You want to rinse your mouth after use with these. There's a high incidence of thrush, which is a yeast in the mouth. And so you want to rinse after using them, and also you can clean the end of the inhaler too. So that's another one. Again, if you're going to give this with albuterol, you'd give albuterol first. Okay? So, mucolytics, I've got an egg here because mucolytics, like acetylcysteine, actually help to break things up that are down in the lower airways, and it smells like eggs. A lot of cystic fibrosis patients use this, and then following or during this nebulizer, then they'll get their vest treatment. Antimicrobials, again, in the cystic fibrosis population are often used. And so there are some things like Nebsin that can be inhaled and are antimicrobials. We're going to move on to the gastrointestinal tract medications. So when we're talking about GI disorders, we're looking at vomiting, diarrhea, constipation, GERD. GERD and reflux fit together. With GERD and reflux, common sense types things really play a huge part in this. Don't drink soda if you've got GERD or reflux. elevate the head of the bed at night, and avoid spicy foods, eat smaller frequent meals. These are real common sense things that people can do to decrease the effects of GERD and reflux. There are many different types of drugs used to treat GI disorders. The types of meds that can be used to treat GI disorders include antiemetics, also anti-barf, emetics or barf, antidiarrheals or anti-poop, laxative or poop promoters. Please add on to this proton pump inhibitors and H2 blockers. These are stomach acid reducers. Please write those down. And then also write this down, anti-gas. Beno, B-E-E-N-O, and simethicone. Simethicone is the generic name for Beno. S-I-M-E-T-H-I-C-O-N-E. So before we move on, let's talk about, and you're going to take notes, is some of the different things that you might use for GERD, reflux, this type of thing. If somebody has this not very often, and it pops up every now and again, they may be using Tums or Gaviscon. Now, Tums is calcium carbonate, and Gaviscon and Maalox both are aluminum and magnesium products. Maalox actually comes with a product, Maalox Max, that comes with aluminum, magnesium, and an anti-gas, simethicone, which is an added plus. Be real careful with the Gaviscon and the Maalox because they do have magnesium in them. You can have magnesium buildup in those patients that are elderly and or have some reduced renal function.